Bismillah ar-Rahman ar-Rahim. Thank you very much for having me in this very important European Atherosclerosis Society Lipid Clinic Network webinar, which is taking place in collaboration with the team in Shifat Amir Millat University. First of all, I'm very thankful for inviting me, especially to Dr. Fouzia Sadig, and also our two speakers today, Ms. Quratul Ain and Ms. Madeeha Khan. I'm sure we are going to hear a lot about the lipoprotein A and its significance in terms of familial detecting familial hypercholesterolemia in Pakistan. By way of just introducing and sharing some perspectives from my side, uh, I would like to set the scene for all of you because I consider myself as a student of health systems, and I'm currently, as you know, working as a professor of health systems and population health in School of Universal Health Coverage in this university. So I would like to bring the broader picture to the whole discussion. And to begin with, I would like to remind all of ourselves that the 2010 was a very critical year in Pakistan from epidemiological transition point of view, because that was the year when the burden of disease in Pakistan shifted more than 50% towards non-communicable diseases. And before that, it always was communicable diseases. And most of our policies and most of our resources were directed to address and prevent and treat communicable diseases. But when the balance tilted towards non-communicable diseases, then a lot of policies and a lot of discourses started happening in this direction. In order to qualify what I just mentioned, a recent study on burden of disease in Pakistan in collaboration with the IHME took place, and it has brought out two very important points, which I would like to share with the participants of this webinar. The first one is that, and this is a study, this is not a small time study. I mean, this covers 3 decades of transition of health, burden of disease and healthcare in the 5th largest country in the world. So this is very important. And to the credibility of this study, I must also add that the government of Pakistan did this study in collaboration with IHME, International Health Metrics Network Institution, Institute of Health Metrics Network. This covers a period between 1990 and 2019, which makes it about 3 decades. And in 2019, when the data was analyzed for burden of disease for 25 leading causes of disability adjusted life years, it was found out that whereas in 1990, when the same exercise was done, the ischemic heart disease was in the rank of 8th among the 25 most important causes of disability adjusted life years in Pakistan. And when this data was analyzed over after 30 years in 2019, the ranking of the ischemic heart disease has gone up to the second most important problem in Pakistan as a cause of disability adjusted life years. So this is very critical because this shows us the trend that how fast the coronary heart disease, atherosclerosis, cardiovascular diseases in general are rising, even among the non-communicable diseases. So I think this is a very important big picture within which we should undertake this work, undertake this research, because this will keep us reminding us that what we are doing is so critically important from public health point of view. The second very important finding of this burden of disease study is that if we just look at not just the causes, direct causes of the DALYs, but if we just look at the risk factors and their relative importance for human health in Pakistan, this study tells us that among the 20 most important risk factors for human health, the seventh most important risk factor is actually high density lipoprotein and low density lipoprotein cholesterol related factors, or dyslipidemia as we call it, which is actually more than these two factors. It has a seventh ranking in terms of attributable risk to any factor which is affecting negatively human health. So I have tried to look also for some credible study which tells us about the prevalence of dyslipidemia in Pakistan while I was preparing for this webinar. And I could only find two studies, one of which tells us that the dyslipidemia has gone up to 90%, and another more than 90%, and another one is telling us that it has gone beyond 70%. The 90% one is the latest study. So if this is the the scale of the problem, obviously the preventive approaches to healthcare are critically important, and ideally we need to be doing a universal screening for lipidemia and its incidence. And if not universal, then maybe as we know, cascading screening at least should be happening. So in this whole context, I think it is very, very important that we have much better idea for some other non-communicable diseases in Pakistan, for example, diabetes, for hypertension, but we have less information about dyslipidemia. And I think that it is very important that we conduct this at a national level, but within which, as a subset, the familial hypercholesterolemia on which the focus of this work is also very important for two reasons. First, that we know now the genetic markers for this, and we also know that it can be prevented if it is detected early. And a lot of disability-adjusted life years can be averted. So I think in that context, I'm very pleased to know about this. And I really want to congratulate Dr. Fouzia and her team and her collaborators internationally that this work is happening. From university perspective, from public health perspective, I think this will actually add immensely to our understanding about the problem, not only about its prevalence and incidence, but also it will guide us that what preventive and curative actions should be included in our health policies and implemented through our primary health care, both in public and private health sectors. So wish you good luck with all this, and thank you very much for having me. I will be available for maybe another 5 minutes, but unfortunately I'll have to leave. My loss, but I will discuss with Dr. Fouzia later about the outcomes of the webinar. Thank you very much.
Thank you very much, Dr. Mirza. It's an honor to have you here. You being the former health minister and director of Universal Health Coverage School within our university is a is always helpful. Welcome everybody for the first awareness session on lipoprotein little a. I'm Dr. Fouzia Sadig. I'm Director of Research at Shifat Amir Millet University, and I'm also the National Coordinator for Lipid Clinic Network, European Atherosclerosis Society, an initiative led by Professor Catabano in Italy. Okay, so today we have two speakers, Ms. Quratul Ain and Ms. Madeeha Khan, who will be sharing their insights on this topic of lipoprotein little a. Qurat will be talking about lipoprotein little a and its role in atherosclerosis, and Madeeha will be talking about lipoprotein little a, its measurement and management. Now, both of these talks would last for 20 minutes, and at the end of the presentations, we will have question and answer session. You please, all of you, the audience, can write their questions in the chat box, and we will try to address all of the questions as much as possible at the end of the presentations. And thank you very much once again for joining us. I hope you enjoy the session. Over to you, Qurat. Thank you.
Hello, everyone. Thank you, Dr. Fouzia Sadik. And I am Quratul Ain, and I am research assistant at Shifat Amir Millet University. And I'm also a PhD scholar in Commerce University, Islamabad. Today, we are going to discuss about the lipoprotein A and its role in atherosclerosis, which is a complex condition underlying various cardiovascular diseases. So let's explore it together. First, we will give a brief overview of lipoproteins, and then which will set the stage for our main discussion on the lipoprotein A. Next, we will explore the role of lipoprotein A in atherosclerosis, and in the last section, we will also discuss about the epidemiological and genetic findings related to lipoprotein A. Now, lipoproteins. Whenever cholesterol, fats, and lipids travel in the blood, they do not travel alone because they are hydrophobic molecules and they cannot travel alone in the hydrophilic environment of the blood. So they need some transporters or vehicles through which they can be transported from one part of the body to the other part. So mostly lipoproteins are the molecules through which cholesterols travel through the blood. There are different classes of the lipids. Lipoproteins including chylomicrons, VLDL, very low density lipoproteins, intermediate density lipoproteins, IDL, low density lipoproteins, LDL, HDL, and in the last, lipoprotein A. Its short form is pronounced as LP little a. When we see at the structure, then we can see that the LPA, lipoprotein little a, has a lipid core in which cholesterol and ApoB100 is present, and outside we can see that there is a unique protein ApoA which is linked to ApoB through disulfide bond. When we talk about these classes of the lipoproteins, these are classified due to their different densities, size, major lipid contents, and apoprotein contents. If we look at the LPA, then the major lipids present in the LP little a are cholesterol, and the major apoproteins present are ApoB100 and ApoA. All of these lipoproteins, including chylomicrons, chylomicron remnants, VLDL, IDL, LDL, and LPA, all of them are atherogenic. It means they can contribute to atherogenesis. They can contribute towards narrowing and hardening of the blood vessels. Only HDL, high density lipoprotein, which is commonly known as good cholesterol, it is anti-atherogenic lipoprotein. Why? Because it travels the cholesterol and fats from the peripheral tissues to the liver for their metabolism. Hence, it leads to decrease in lipid level in the blood. Now, after covering the foundational aspects of the lipoproteins, we will discuss about the LP little a in its function and structure. Lipoprotein A. LP little a particle, we can see in this diagram, there is a LP little a particle, and we can see a lipid core in which cholesterol and ApoB100 are present, and the ApoB100 is bound to the ApoA with the help of disulfide bond. It is important to note that there are different protein domains known as kringles. They are present in the ApoA protein. Regarding its synthesis, lipoprotein A is synthesized in the liver. Once synthesized, half-life is relatively very short, approximately 3 to 4 days. And when we talk about the normal levels of Lp(a), then they are less than 30 milligrams per deciliter or 75 nanomoles per liter. It is very important to note that monitoring these Lp(a) levels are very important for assessing cardiovascular risk and overall health. Despite extensive research, physiological function of Lp(a) still remains unclear. However, it is clear that elevated plasma levels of Lp(a) are significant risk factors for cardiovascular complications like atherosclerosis and thrombogenesis. In the blood, there are different isoforms of the Lp(a), and the circulating isoforms depend basically upon the kringles length. Kringles are basically the protein domains composed of amino acids. There are two major forms present in the blood, small lipoprotein isoforms and large lipoprotein A isoforms. And basically, the kringle 4-2 repeats, they decide the size of different Lpa isoforms. It is also very important to note that the structure of ApoA protein is very similar with the plasminogen protein. They have high amino acid sequence similarity. And then there is another important point to note that small lipoprotein isoforms, they pose an increased risk to coronary artery disease. Now, after covering the introduction of Lpa, we will explore its role in atherosclerosis. What is atherosclerosis? As we know that atherosclerosis is a chronic inflammatory disease which is characterized by buildup of plaques within the walls of the arteries, hence leading to their narrowing and hardening. Then how Lpa contributes to atherosclerosis? It contributes through vessel wall binding, smooth muscle cells proliferations, foam cell formation, and necrotic core formation. This is the cross section of a blood vessel in which we can see that there is a lumen in which blood is flowing and there are outer layers of the blood vessels. So whenever there is high level of Lpa is present in the blood, then the small isoforms, they get leaked through the endothelial cell walls and they move into the tunica intima. In the tunica intima, the Lp(a) is got oxidized by the reactive oxygen species and is converted into the oxidized form, that is oxidized Lp(a). Oxidized Lp(a) molecules or particles, they are considered as exogenous in our body. Our immune system gets activated and the monocytes, they travel on the site in the tunica intima to engulf the exogenous particles that are, in this case, those are oxidized Lp(a) molecules. They engulf, monocytes become the macrophages, they engulf the oxidized Lp(a) particles and they form the foam cells. Monocytes also release some pro-inflammatory molecules, including cytokines, which starts the inflammation at the site. And meanwhile, smooth muscle cell SMC, they also get proliferating and they travel to the site of plaque formation. In the end, necrosis of the foam cells starts the necrotic core formation, and all of these processes, they lead to atherogenesis, that is narrowing of the blood vessels. So now we have discussed that elevated level of Lpa can play a role in is a cardiovascular risk because it can cause atherogenesis. But other than atherosclerosis, there are two other complications which are caused by the elevated levels of Lp(a). Those are aortic stenosis and thrombosis. Aortic stenosis is basically the calcification of valves. Whenever there is a damaged aortic endothelium, then LP little a gets bind to the site and it activates the mechanism and osteoblast, which start the calcification in the valves. And the process is known as aortic stenosis, due to which valves of the heart got dysfunctional. And in the last, thrombosis. Thrombosis is basically the clot formation. Do you remember that ApoA part of the LP little a that was similar to the plasminogen, and plasminogen is the precursor to plasmin. Now what happens that LPA binds to fibrin? How? Basically what happens that ApoA part of the LP little a that is bound to the TPA, that is tissue plasminogen activator, and it does not allow plasminogen to be converted into plasmin. Plasmins are needed to break down the clots. Once this mechanism is halted, then there will be more thrombus clot formation, and hence it will lead to occlusion of the blood vessels, and hence it is a great cardiovascular risk. Now we are on stage that we can say that LP little a plays a causal role in cardiovascular diseases through the processes of atherosclerosis, thrombosis, and aortic stenosis. This is a real data from the UK Biobank, in which it was seen that lifetime risk of the cardiovascular diseases was increasing with increase in the LP median levels. Whenever there is increase, there were different groups having different median LP little a levels, and it was seen that the group having the highest LP little a levels was having the high risk for cardiovascular diseases as well. In the last section, we will cover the epidemiological and genetic findings related to LP little a. First, we will discuss about the impact of ethnicity on LP little a levels. So ethnicity significantly impacts the LP little a levels. Africans have the highest LP little a levels among all other ethnicities. Africans have about 27.1 milligrams per deciliter median levels of LP little a. If we talk about our populations, in South Asian population, the level of LP little a is 13.8. But a study conducted in Pakistan shows that Pakistani population has relatively higher ALPA levels, that is 20.7 mg per deciliter, which is quite high and is second highest among all other ethnicities. So ethnicity impacts the LP little a levels, but the association between the cardiovascular diseases and the LPA level, that is independent of ethnicities. This was a study conducted in UK in which there were two populations, white and African people. In both ethnicities, it was noted that despite of their ethnicity, the risk of cardiovascular event was directly proportional or continuous with increase in LP little a levels. Next, genetics of LP little a. LP little a levels are genetically determined. So you are born with them. That's why ethnicity directly impacts the LP little a levels in the blood. The ApoA protein of the LP little a, that is encoded by LPA gene. And the particular gene is located in chromosome number 6, and it has 39 exons. Regarding its inheritance, each parent contributes one allele to the offspring. So genetics has paved a way for understanding on causality of cardiovascular diseases. There are some genetic variants which lead to lifelong exposure of high LP little a in the blood, which hence lead to increased CVD risk. So there are strong association between LPA increasing genetic variants and the cardiovascular disease risk. For these genetic variants, a study was conducted. There were 3 groups having different variants with increase in LP little a levels. It was noted that the group which was having the highest LP little a levels, and that was having the maximum number of cardiovascular events. So this is the risk ratio diagram in which we can see that the group with the highest LP little a levels was having highest risk for cardiovascular events. However, there are some other genetic variants which decrease the LP little a levels in the blood. And low LP little a levels, they lead to decreased cardiovascular disease risk. So there is strong association between LP decreasing genetic variants and CVD risk. In the last, summarizing my talk, what is LPA? LPA is basically a LDL bound to ApoA with genetically determined levels. So you are born with it. Elevated levels of LP little a contributes to atherosclerosis by promoting cholesterol deposition, inflammation, and impaired clot breakdown. Elevated levels of LP little a pose increased risk of atherosclerosis and cardiovascular events. Measuring the levels of LP little a are very important to assess the cardiovascular risk and the overall health. This will be discussed in detail by my fellow speaker in next session. I would like to acknowledge and thank Mr. Professor Khatapeno and the media team of the EAS Lipid Clinic Network for organizing this webinar, and thank you all for joining this webinar. Thank you. Over to Dr. Fouzia.
Thank you very much, Kura. That's wonderful. Thank you. Okay, so our next talk is from Madeeha Khan. Madeeha, over to you. You can talk about the diagnosis and management of lipoprotein little a. Thank you.
Thank you, Dr. Fouzia. So I am Madeeha Khan. I am currently working as research assistant at Shafat Amir Millet University and also doing my PhD from National University of Sciences and Technology, Islamabad. So I'll be continuing the discussion on lipoprotein A, specifically focusing on its measurement and management. Also, I'll be talking about how we can incorporate LP little a in risk estimation and the treatment options available for treating elevated LP little a concentration. As discussed by my fellow Quratul Ain, that LP little a, it is a causal risk factor for cardiovascular diseases, including aortic stenosis, heart attack, and stroke. It has also been identified as a causal risk factor in Pakistani population. However, LP little a testing, it is not considered in routine diagnosis for cardiovascular diseases. So before going into details about LP little a testing and measurement, I would like to give a brief introduction about the European Atherosclerosis Society consensus statement paper that was published in 2022. This paper, it brings together evidence for the elevated levels of LP little a and their association with cardiovascular diseases. Also, this paper, it incorporates a novel recommendation of including LP little a in clinical practice. So according to the EAS consensus panel recommendation, LP little a levels, they should be measured at least once in the lifetime of individuals, preferably with the first lipid profile. In case of youth, the screening, it is recommended in case of history of stroke or family history of very high LP little a levels or premature ASCVD. Similarly, the cascade screening or family screening, it is recommended in the settings of familial hypercholesterolemia or family history of very high LP little a levels or atherosclerotic cardiovascular disease. With regards to assays that are used for measuring LP little a, the panel, it recommends that the assays that should be used to measure LP little a, they should be isoform independent. As we have seen previously, there are two different isoforms of LP little a. So it is recommended that isoform insensitive assays, they are utilized, that gives concentration in molar units. However, if those kind of assays, they are not available, then the assays that give concentration in mix per deciliter, they can also be used. Also, the panel recommends that instead of the absolute values, the clinical guidelines, they should actually consider using a threshold that rule out those individuals that have LP little a levels less than 30 mg per deciliter, and rule in those with 50 mg per deciliter levels as for with high as being as have a high risk for cardiovascular disease. The interim gray zone from 30 to 50 mg per deciliter, these are the individuals that are at risk, but we need to consider the traditional risk factors among them. What are the traditional risk factors? I'll be talking about them in a while. So if we consider the LP little a levels in Pakistani population, as I have said earlier, that it is not included in the routine diagnosis, but there was a study conducted among some 1,000 individuals that shows that more than 21% of the population, it had LP little a levels greater than 50 mg per deciliter, while more than 16% they were included in the gray zone, meaning they were also at a risk for developing cardiovascular diseases. So how can we incorporate LP little a for risk estimation? So this figure here, it is derived from the same consensus paper. So this is the data of some 400,000 individuals of European ancestry. So here on y-axis, we have the baseline absolute risk for cardiovascular events, while on the x-axis, we have the baseline risk that is coming from the traditional factors. So the traditional factors, these can include age, gender, blood cholesterol levels, blood pressure, diabetes, family history, BMI, etc. So the first, the initial bars, they come from people with LP little a levels that are very low. And the subsequent bars, these represent the increasing LP little a concentrations, and the number here, this is the additional risk factor or percentage that is added to the baseline risk with increasing LP little a concentrations. For instance, if a person has, if individual has LP little a levels of 50 mg per deciliter, so their baseline risk, which was previously 5%, it increases to 7%. The 15% risk, it increases to almost 21%, and the 25% risk, it increases to almost 35%. So roughly there is 1.4-fold increase in the risk for developing cardiovascular disease. Similarly, for higher LP little a levels, like for 150 mg per deciliter, the risk it increases to a huge extent. Like the 5% risk, it increases to 14%. The 25% risk, it increases to 68%. So there's roughly 2.7-fold increase in the risk of people with elevated LP little a level. So what can we conclude here? We can conclude that if LP little a level, they are not considered, so the absolute risk, it is underestimated substantially, and hence the management plan, it is also affected. Now we know that LP little a is a causal risk factor for cardiovascular diseases. So what are the treatment options and how we can manage those? So the specific LP little a lowering therapies, they are still in the trial phase. All of the three mentioned here, they have been shown to be very effective in the trial phase. They have been shown to be effective in lowering the LP little a levels by 80%. The first one, pelacarsen, it has been widely tested, and it is expected that the results they will be available by 2025. So what can we do if the specific LP little a lowering therapies are not available? So the answer comes from managing the traditional risk factors, which I was previously discussing. So in the absence of this specific lipid lowering therapy, it is important that the traditional risk factors, they are managed effectively. Also, in some countries, lipoprotein apheresis, it can also be conducted for people with very high LP little a levels. Niacin and routine aspirin, they are not advised for managing LP little a levels. So talking about the traditional risk factors and their role in management of elevated LP little a, so one of the most important traditional risk factor is low density lipoprotein cholesterol, or LDL-C. So if we effectively reduce LDL-C, we be able to control the risk which is posed by high lipoprotein A levels. So there's this figure, it represents a population which was divided into three groups. The one in blue, it's the reference group with normal LP little a levels. The one in green, they have higher LP little a levels and lower LDL-C levels. while the one in red, they have both higher Lp(a) levels and LDL-C levels. So here we can see that lifetime exposure to 0.5 millimole lower LDL-C, it can lower the risk of major cardiovascular event at all ages. Again, this table, it represents the quantitative estimate of the intensification of the LDL lowering therapy that is required to lower the risk for cardiovascular diseases. So as we can see here, that if the lipid lowering therapy, LDL lowering therapy, is started late, so there is greater intensification of the lowering therapy required if the treatment is started late as compared to if it is started earlier in lifetime. So what is the bottom line? The bottom line is that starting prevention early is the key to mitigate the risks for cardiovascular diseases. Talking about the status of lipid lowering therapies in Pakistan, so statins and ezetimibe, they are highly prescribed and available throughout the country, but advanced therapies like PCSK9 inhibitors or intersan, their availability throughout the world, it remains an issue. So in order to mitigate the risk for cardiovascular diseases, it is very important that these advanced lipid therapies, they are available throughout the world. Okay, so summarizing all that we have discussed today, we know this now that Lp(a), it is a causal risk factor for atherosclerotic cardiovascular diseases, and it should be measured at least once in the lifetime of individuals. The Lp(a) lowering therapies, they are still in the clinical trials phase, so it is important that the traditional risk factors, they are managed effectively in order to mitigate the risk of cardiovascular diseases. In the end, I would like to thank the ES Consensus panel chairs, co-chairs, and panel members for putting forward these recommendations for Lp(a). And we would like to thank the ES Lipid Clinic Network team for managing and providing support for this webinar. That's all from my side. Thank you so much. Over to you, Dr. Fouzia.
Thank you very much, Madeeha, and thank you very much, Qurat, for wonderful presentations. Now we have some questions in the chat box. If I go through the questions, let's see. Okay, so we have a question from Dr. Sabine Khan, and she's asking, what are the recommendations for checking Lp(a) among children?
Okay, so as I mentioned earlier, that in adults, it is important to measure Lp once in a lifetime, and in case of children, it is we can measure the Lp(a) levels in the with the history of stroke or family history of very high Lp(a) levels or family history of atherosclerotic cardiovascular diseases. So these are the recommendations for measuring Lp(a) in children. I hope that answers your question.
Yeah, that's fine. As you know, in those cases, you know, if Lp(a) is measured among children, that can predict lifelong cardiovascular disease risk factors. There's another question from Amjad. He's asking, do I need to get my Lp(a) testing done regularly? No, Amjad, you only need to get yourself measured for Lp(a) once in your lifetime. It's a genetic marker, so once you've got the value, that's it. Among women, you know, postmenopausal, there could be changes in Lp(a) levels, but that's a different story. There's another question from Ruba Fatima. Which test allows us to check the lipoprotein (a) levels? Any one of you can answer. If not, I can answer. Madeeha?
This test, if you're asking the name of the test, is just lipoprotein A. It's not the routine lipid profile is different from that. And if we talk about the analytical technique, so mostly it's ELISA based or the protein based method that is used for measuring Lp(a) levels.
Yeah, it's immunological testing. Other questions, is Lp(a) testing facility available in Pakistan? The answer to this question is yes. And Chughtai Labs, they do it for diagnostic purposes. We also, like there are kits available, and we'll be testing those for our research samples. So if anybody's interested, they can approach us. We're not there yet, but we'll be testing those. The other question is, if lipid therapies are not available, then why should I get tested? Would you like to answer, Quratul or Madeeha? Anyone? You're
Okay,
mute.
so as I've said earlier, that the specific LP-little lowering therapies, they are not available. But we know about the traditional risk factors that are important, like LDL-C levels or blood pressure or diabetes. So there are therapies for managing lipid levels, LDL level, cholesterol levels, statins, as I said, there are statins and ezetimibe that are available. So if we manage those, we'll be able to lower the risk of a person who has higher LP-little levels. It's a risk factor, no doubt, but managing the risk factors like the lipid levels or the diabetes or hypertension, managing those, it can actually be effective, especially if the LP-little lowering therapies are not available. I hope this answers your
Sorry,
question.
one of you can mute yourself. Okay, yeah, that's correct, Madeeha. Okay, so who asked this question? One of the students probably asked the question. The thing is, because it's a genetic marker, so the sooner you find out about this, the earlier you can start managing it through traditional medication, and that would prevent a premature cardiovascular event. Okay. There's another question. Any gender differences in LP-little-A? Any one of you can answer? Did you find any gender differences in LP-little-A?
Am I on, can you hear me?
Yeah.
Women's in our study, basically, we also did a cross-sectional study in the Pakistan, and it was observed that women were having less LP-little-A levels, probably due to their hormonal changes.
No, but was that, during the adult,
Yeah.
you need to correlate with the age as well, because it varies later in the life, post-menopausal, as I said. So if you analyze LP-little-A between 20 and 30, was there any difference?
Yes, after the age of 40, we observed that women were having less LP-little-A levels as compared to the men.
Yeah, but during the early age and like when they were between 20 and 30, was there any difference?
There was also a difference, small difference, but that was not significant when we checked through the stats. So.
Okay. There's a question. I want to know which analytical techniques are sensitive for measuring LP-little-A. Other than the immunological, Madeeha, would you remember?
As far as I know, the gold standard or the best techniques, they are the immunological techniques. And among those, there are also two types of techniques, as I've said earlier, isoform insensitive and sensitive. So the isoform insensitive method, it is generally recommended. However, it's a little bit difficult because you need monoclonal antibodies for all the epitopes of LP-little-A. So mostly in labs, especially around the world, they use polyclonal antibodies. There is a bit of difference that might be coming from those techniques. but still it's valid. And there are working groups that are working on giving recommendations related to reference material or the standard techniques, standardization of the techniques, which might be available in the future. So we will have a better idea of which techniques are better for measuring LP(a).
Yeah, and then there was this thing that, like I think Kurat mentioned that units are very important. You can't convert mgs per deciliter there is no conversion factor for mgs per deciliter into nanomoles per liter. So one has to be careful what units you're using to report the assay. There's a question, is there any association of lipoprotein a with diabetes?
Yes, there are many studies around the world which say that actually low levels of LP(a), they are actually associated with diabetes. As the elevated levels of LP(a), they are associated with cardiovascular diseases, but with diabetes in diabetic patient, it is observed that there is association of low LP(a) levels with the incidence of diabetes.
With the incidence of diabetes. Someone's asked, what is the ideal age to get LP(a) level checked?
So as I've said earlier, that the levels, they are reach the optimal when you are adult, like 18 years old. So once you are adult, you can check the levels once in the lifetime. So there's that you can do it when you are 18 or whenever adult. But again, as I've said earlier, that in children, it is recommended if there is a family history of some sort of diseases, or the family, if they get their LP(a) levels checked and they have very high LP(a) levels. So in that case, the cascade screening or the family screening is recommended. So that can be done regardless of the age. But yes, once you're adult, you need to get your LP(a) levels checked.
Yeah, so you only need LP(a) tested once, as I said earlier also. Once you have the number, once you find out what your LP(a) concentration in the plasma is, you just look at it. If it's above the range, if it's D range, please go to the doctor and start managing it there and then, because if you delay management of your LP(a) lipid levels, then as Madeeha showed in her presentation, you're more likely to develop cardiovascular event early in the life. Okay, will we receive a certificate for this webinar? Yes, you will. Is there some way to lower LP(a), or is it mostly only influenced by genetics?
Okay,
Madeeha.
so as I've said earlier, that obviously the LP(a), they are influenced by genetics, but there are specific therapies that actually target the production of the apo(a), and in turns it influences the production of LP(a), and it actually lowers the production of LP(a) in the hepatocytes, since it is produced in the hepatocytes. So the therapies, they can actually hinder the production of LP(a). But again, those therapies, they are in experimental trials, so we need to wait for their effectiveness. Although they have shown their effectiveness, but again, we need to wait to get the final results.
Yeah, it's
I
just
would
a
like
matter
to
of
add some
time.
point. Levels of LP(a), they can also be lowered. They are actually, it is being practiced that lipid apheresis technique has been used, but that's not effective. Although it is being used for the cases who are very severe and are very at high risk of the cardiovascular events. So, but it's not recommended because again, these are genetically determined levels, and the half-life basically of LP(a), that is 3 to 4 days. And once you remove it from your blood, then again you can make it, because your liver is actually effective for making the LP(a). So again, it will produce it, and again you will get higher LP(a) levels if you have a bad gene for LP(a).
That's correct, Kurat. Thank you for adding that up. LDL apheresis has been used, although it's not readily available in Pakistan, but in the developed world, I have noticed that people undergoing LDL apheresis, the levels of the levels of LP little a, they rise back to the same level. You know, within a week, it comes back to the same level. So it's one has to undergo weekly LDL apheresis to keep a check on LP little a. It's very tricky. There's a question from Masil. Any effect of exercise on LP little a over a person's lifetime?
So as we have discussed earlier, that LP little a, it is genetically determined. So lifestyle changes like, healthy diet and exercise, it will not directly lower your LP little a levels, but it is helpful in managing the traditional risk factors that you might have, like the high cholesterol or hypertension or diabetes. So it might be effective in that and reducing the cardiovascular disease risk, but not for lowering LP little a. That's where the problem is.
That's right. Okay, so somebody says that Nadia Noreen, ma'am, I've worked on telomere length in myocardial infarction. Is there any medicine to maintain telomere length to control premature heart attack? Okay, I think we shall discuss that later because it's not directly related to lipoprotein little a. But if anybody else has any question, we've got 3 minutes before we close this session. So if there is any other question related to lipoprotein little a, please ask, write in the chat box. If there is no other question, then
someone
thank
is
you.
asking about the recorded session, so it will be available and it will be shared with you.
Yeah. I don't think there is any other questions. So thank you very much once again, Madeeha, Qurat, Eliza, Lipid Clinic Network, Team Eliza, and Frederica. Oh, there's another question. Symptoms. Symptoms. Okay. Well, same question. You want to comment on that, Qurat?
There are no direct symptoms related with it, but you can actually, you are at high risk for incidence of cardiovascular diseases. There is no symptom of elevated LP little a levels.
Yes, thank you very much. Thank you. I think with this, once again, I thank to both of the speakers, Dr. Zafar Mirza for his insightful opening comments, and Eliza and the Lipid Clinic Network and the media team, and Professor Katapano for taking this initiative forward very effectively. Thank you very much once again. Goodbye, everyone. Thank you.